All right, so now we'll cover the ins and outs. So when you take the baby home, we're gonna discuss what goes in, what comes out, so the pee and poop. This may vary from infant to infant, and also it varies depending on the gestational age, but we'll just do a brief overview. All right, so the first 24 hours, we wanna attempt to breastfeed if possible on demand. They are advised to offer feedings every 2 to 3 hours at a minimum, but you can go on hunger cues, which actually develops a little later. Some babies might actually need to be fed every hour. So some hunger cues would be rooting, putting their hands in their mouth, clenched fists, lip smacking, or a hunger cry in the Dunstan baby language, which sounds like, nah, I'm not gonna do it. It's a good idea to get them on a schedule if that works for you. If not, it's absolutely fine to feed on demand. We just want a minimum of every 2 to 3 hours. Some babies tend to cluster feed on evenings, which should keep them fuller for longer periods overnight, which is fine if you want to do that. So how do you know that they're getting enough? The main thing that we look at is the number of wet diapers in 24 hours. A good rule is to expect 1 wet diaper per day of life until day 5, and then you want to see 5 or more per day per 24 hours. So within the first 3 days, the poop will go from really dark and sticky to yellow and watery or pasty when they start digesting milk. Within the first 3 days of life, especially for new parents, the baby and the mom, they're both going to be figuring out breastfeeding. It comes naturally to some people, that's fantastic. And I feel like the majority of moms, it will be a learning curve. Most hospitals have a lactation consultant on staff to help new moms figure out the best ways to hold the baby, the best techniques. I highly recommend this if your insurance covers it, to set up at least 1 consultation with a lactation consultant after discharge. And so remember, just as you are learning, the baby is also learning how to breastfeed. There are a lot of instincts involved with it, of course. I had a doula when I gave birth, and she also coached me in breastfeeding shortly after. She was also a lactation consultant. And it was actually fascinating to find out or learn about all of the instincts that the baby already has. Like, they know how to, the scent of the milk actually is very powerful for them, so they know how to find it, like root it out, crawl towards it or try to crawl. It's actually pretty fascinating. But yes, it's a learning curve. It'll take a couple days and you just have to keep trying. So how do you know that they're getting enough? Like I said, just look at the number of wet diapers, which actually is not that much in the first 3 days. So there are some special mentions. So for underweight babies, defined as those that are less than the 10th percentile for their gestational age. So example, at full term, this would be less than 5 pounds, 8 ounces, or 2,500 grams, or those whose moms had gestational diabetes. The glucose will be checked in the hospital because these babies tend to be unable to maintain their blood glucose well within the first 48 hours, sometimes 5 to 7 days. This is really important. And I know this causes some anxiety in young parents because a blood glucose check is done with a needle. You have to stick it, you have to check the blood. There's no other way to check it at this point. And so a lot of parents might be concerned about this. It's important, and I'll tell you why. In older kids and adults, if we skip a meal or we are fasting for a prolonged period, the body, actually cells, can only use glucose, which is the simplest form of sugar, right? And we have stores. So we have glycogen stores in the liver, in the muscle, we have fat stores. So we can tap into that and use it. The body can't use whatever is ingested, whatever is stored in the body has to be converted into glucose as a first line to use. So these babies are not able to really maintain their blood glucose levels very well, which is why we have to check it very closely. There are 2 separate reasons for each instance. So babies who are a little lower on the weight curve, while they are in utero or in the belly, remember the placenta continuously offers nutrition to them 24/7 because it depends on the blood flow. And so they're getting this sort of continuous infusion, if you will, of yummy glucose. When they're born, their metabolism changes into one that, when they eat, they get this like big load of glucose, and then they have to figure out how to process that. And so it goes from this nice continuous infusion to big loads of glucose at certain intervals when they're eating. So it takes a few days for them to figure that out. And in the meantime, their blood glucose might just, have these big drops, which, as everyone knows, is dangerous. You do not want your blood glucose to drop too low. In babies, it can actually get down pretty low without affecting them. The lowest that we will accept is 40 in most hospitals, whereas for an adult, you never want to go below like 75. So that's for really babies who are on the lower end of the weight curve. For babies who were born to moms with diabetes or gestational diabetes, the reason is a little different. So these moms tend to have higher insulin levels in their body, and so the babies are exposed to higher insulin levels. And so when they're born, there's a little bit of a lag until their own metabolism takes over and their body starts to regulate their own insulin levels. So for a couple hours, it varies in a lot of babies, they will have these like high insulin levels still, which causes very low glucose levels. So that's why we need to monitor it very closely. And so what do these babies with the low glucose levels look like? So just know that once you're in the hospital, a nurse will be dedicated to that baby and she will keep her eyes on that baby 24/7. This is why I see like all these funny videos about, the first 24 hours after labor, the nurse is always sticking her head in. That's true, but it's also for the baby. They have to keep a very close eye on that baby. But what you might notice is the baby is jittery or just like very, shaky, like really the arms and legs are shaky, or just really excessively sleepy. I mean, all they do is sleep in those first 24 hours, but to the point where you're trying to wake them up to breastfeed and they're just not waking up. So just like really sleepy or jittery would be the two things that you look for in these newborn babies that might signify a low blood glucose level. So now we'll address just a couple interesting facts about newborns that I think are overlooked a lot. So one of them is the soft spot on top of the head, or what is called the anterior fontanelle. So it's a normal gap between the skull bones located at the top and front of the head. In most babies, it's diamond-shaped and typically flat. It tends to close anywhere between 10 to 24 months of age, so there's a wide gap. If it's pulsating when the baby's angry or agitated, that's fine. If it's always pulsating or seems tender, that can be a sign of something pretty serious, so you'd want to get that checked out. If it's sunken in, that might mean that the baby is dehydrated or just not getting enough breast milk or formula. So these two things are something that you would want to bring up to your pediatrician if it's pulsing, too domed, or too sunken in. All right. So then around months 2 to 3, some babies may develop something called cradle cap. Actually, it can range from 3 weeks to 12 months, and it tends to peak around 3 months of age. The cause of the cradle cap is not very well understood, but it's thought to be related to maternal hormones, stimulating growth of the sebaceous glands or the oily glands that produce skin oils. There's also a fungus that can grow on the skin that can play a role in this, but it's not clear how. It is harmless and it will go away on its own within months. But if it's very severe, you can talk to your pediatrician about using medications to help just clear it up more quickly. So they will offer either a topical corticosteroid or ketoconazole, which is an antifungal cream that you can use twice per week for 2 weeks. So what the cradle cap will look like, sort of like dandruff, but for babies. In some babies, it can be like yellow and greasy, flaky, tends to happen around the anterior fontanelle that we just spoke about. And in a lot of babies, it may fall onto the face, and then it might start affecting the eyebrows and the cheeks where it falls. And so there are a lot of shampoos and natural remedies that are on the market that I think helps. Essentially what it does, it softens up the flakes, and then you're able to wash this off and sort of scrape it off so that you see less of it. It doesn't really get rid of it. It makes it less obvious, so you don't really see it. I think that's totally fine. The medications, however, will get rid of it, but in babies this age, there are always risks involved. And so you don't have to do it. The cradle cap is not harmful at all, and it will go away by itself, just with a headband or a hat, I think. It's really, I don't think medications are really needed, unless it's pretty severe and you feel like it's irritating the baby. So let's talk about some other common skin issues. Newborns have the most rashes, probably second to teenagers. Think of a hormonal teenager. So as smooth as a baby's skin usually refers to later on after mom's hormones are no longer in their system. So about after 3 months of age, then you get the typical like beautiful, smooth, glowing skin. So just know that a lot of newborns have rashes. It's totally common, nothing to worry about. So there are a lot of newborn rashes. I probably will have to do a dedicated video on that one because it's so extensive, but briefly, the most common ones are etox or erythematoxicum, and this will look like fine, tiny red buttons on the face, on the body. It's totally normal. It's not harmful at all. And really, as we spoke about, these are just mom's hormones in the body, just causing like a little bit of inflammation in the skin, and just like a little bit of agitation. You'll notice that when the baby is cool and dry and calm, it tends to show up less. When they're screaming and crying, really hot and sweaty, or like after a warm bath, you will see that it raises up a little. So that's etox. They will outgrow this. Newborn acne is another big one, and it is exactly as it sounds. It's acne on the baby's face, again from mom's hormones. It tends to show up around 2 to 4 weeks of life, and then very slowly it will go away by itself as well. Another one is milia, so you'll notice tiny white bumps, typically on the nose, that again will go away by itself, totally not harmful at all. So some birthmarks can look pretty intense, big sort of pink red ones. You can get it on the forehead right here or at the back of the neck. We call it like a stork's bite and a stork's kiss. Those will fade with time. The more involved ones would be like, for example, a port wine stain that tends to be larger, more of a dark reddish hue. That will definitely need to be discussed with your pediatrician. And then we have hemangiomas, which are actually little vascular birthmarks, and they tend to look, the most common one would be a strawberry hemangioma because it looks sort of like a strawberry. It's red and raised. They can actually show up anywhere on the body and even on the vocal cords, which we will also have to talk about in a separate video because that is more involved. But the hemangiomas, in most babies, they will go away by itself. So it tends to get bigger before it gets smaller and shrinks completely. But there are instances when you would want to have this checked out by a pediatric dermatologist. And so I'm not going to get into all of them, but definitely discuss it with your pediatrician. It tends to be if you have multiple hemangiomas or if it is located in a really sensitive spot like close to the eye or close to the lip, close to the genital area, or if it is pretty large in size. In that case, a dermatologist would need to be involved in care, and we can prescribe medications that can help that shrink. We would want to do this because it is a vascular birthmark, so if it's really large, it can start to steal the blood supply from neighboring organs or other parts of the body. And so that's why you definitely want to get that treated in a timely manner. So now let's talk about colic. So colic is broadly defined as crying for no apparent reason. For example, they're not hungry, they don't have a soiled diaper, they're just crying. That lasts for more than 3 hours per day, that occurs on more than 3 days per week, in an otherwise healthy infant less than 3 months of age. Causes. So it's not clearly defined, but many causes have some evidence to support it. In most cases, it's a combination of factors, and so we are going to talk about some of them. Some of them have a lot of evidence to support that this may be the leading cause. Some have weaker evidence, but I would say discuss this with your pediatrician or someone who knows the baby very well, and then you can start trying solutions based on the most likely problem. What I do in practice is I take a very broad-based approach, and I try to take the parents or the mom's preferences into consideration. So for example, if I think that a huge factor that might be contributing to this is improper feeding techniques or excessive swallowed air, but the mom definitely wants to do direct breastfeeding and is not interested in pumping, I think that's totally fine. Then I would just get a lactation consultant to be super involved in the care of this infant so that the mom can optimize breastfeeding in a way that is comfortable for the baby. So let's get into some. The first one is feeding techniques. So you can have over swallowed air, improper burping. Definitely, I would say working with a lactation consultant is the most helpful in this case. The second one is a cow's milk protein allergy or intolerance. If this is the case, there may be other physical signs that can lead to this diagnosis. For example, not just the continuous crying, but also an eczema-like rash on the baby, difficulty gaining weight, so poor weight gain, or really loose, watery, sometimes even bloody stools, or stools that have a lot of mucus in it. So all of those things combined may lead you to believe that it's a cow's milk protein intolerance. I also forgot to mention, a lot of spit ups or excessive vomiting and just overall irritability might lead you to believe that this is it. So it's just one factor that can contribute to colic. And so in a case like this, you may want the mom to go on a trial of a dairy-free diet for about 4 weeks. In some babies, they will show immediate relief. In most babies, it'll take about 2 weeks to see any difference. But in a large number of babies, it can take up to 4 full weeks to see an improvement. So it's sort of a long road, but that's the time frame that you need to work with. If the infant is formula feeding, you can try a hydrolyzed formula or a broken down formula. And what that means is the milk protein is still present, but it is present in its most broken down and basic form, so it's easier to digest. And this actually tends to help a lot of babies who have a highly suspected cow's milk protein intolerance. A while ago, they were recommending high fiber formulas, but actually this is not recommended anymore. It has not been shown to help at all. It's not beneficial at all. So another factor that might be contributing to colic is gastrointestinal or nervous system immaturity. There is weak evidence to support it, but it's really good in theory. And when I say weak evidence, I just mean that there have not been many high quality studies looking at this. So high quality would mean large multi-center studies looking at thousands of babies. So just because we haven't done that doesn't mean that this isn't contributed. And actually, a lot of soothing techniques and infant physical therapy or PT manipulation has been shown to help with infants with colic. So I would still recommend looking into that for parents whose infants have severe colic and none of the traditional methods are helping. I think infant PT manipulation can help in cases like that. Another theory that we have is something called intestinal hypermotility. There is conflicting evidence in reality. A while ago, some pediatricians would try motility agents. That has not been shown to help at all, and so we do not do that anymore. And then the last one would be alterations in fecal microflora. I know recently there has been a lot of discussion around gut health and the gut microbiome, which I think is great. Your gut health is closely related to your immune health and your brain health. We'll get into that. But when babies are born brand new, remember, they are not exposed to these bacteria inside of the mom, like in utero. So when they're born and they start breathing their own air and like drinking breast milk, then they start getting exposed to these bacteria. And a lot of it largely depends on the mom and the mom's microbiome and microflora. A lot of babies will get their healthy gut bacteria from mom's skin while doing direct breastfeeding. Even when you're pumping, the pump itself comes into contact with your skin, so you do get some of that healthy bacteria. But just by existing in the world, they get this bacteria inside of them. As with anything, you have a period of growth and then you have a period of stabilization. And so around 1 month of age is when babies tend to get super gassy and fussy because they're getting a lot of these healthy gut bacteria, and so the bacteria are producing like a lot of gas, and so they tend to get gassy. So there is ongoing research on this, but we don't have a lot of evidence just yet. L-reuteri therapy has been shown to decrease symptoms in some studies, but it is not routinely recommended right now because probiotics are not evaluated by the FDA. Therefore, every ingredient has not been vetted, although some studies have shown them to be effective at reducing crying times. So, what can you do to help your infant? I know colic is just one of the most difficult things that you can go through in early childhood. Some studies have shown that pacifier use is associated with less crying time, or taking the infant for a walk or a ride in a stroller or a buggy. Just the movement tends to help them. Or holding the infant or placing them in a carrier, so a lot of baby wearing, your nervous system helps regulate their nervous system. Or rocking the infant, movement tends to help a lot. Or just changing the scenery so you're minimizing visual stimuli. Or placing the child in an infant swing, remember only when they're awake, they can't sleep in the swing. Providing a warm bath, rubbing the infant's tummy or giving them little tummy massages. Using a white noise machine has also been shown to help. And so you'll find a pattern in all of these, right? They are all tend to calm an overactive or abnormally active nervous system. So with the rocking, the soothing, this different changes in scenery, stimuli, holding them, and that is where the gastrointestinal / nervous system theory comes into play. Like I said, we don't have a lot of evidence, but the solutions have been shown to work, right? Which is why I also think infant PT manipulation can help. And there are a lot of great accounts that show you how to move with your infants and babies to help calm their nervous systems. All right, and then the last thing that we'll talk about is reflux. So reflux and infant gassiness, which are not the same thing but are related, can be associated with milk protein intolerance, or what we call a physiological reflux, as in the muscle itself, called the lower esophageal sphincter, is weak, and so undigested or partially digested milk flows right back up into the mouth, the back of the mouth or the back of the nose and throat, and comes right back out as vomit. So in most babies, this is gonna be physiological reflux. A lot of babies, especially premature ones, are born with this muscle being just a little bit loose, and that's totally normal. These babies tend to grow out of it, and it doesn't cause too much of a problem. And so these are the babies that will spit up slightly or just be happy spitters, and some reflux precautions is generally all it takes to make them comfortable. So just some things that may help reduce reflux actually would be to avoid tobacco smoke, so smoking around babies. Breastfeeding infants also tend to have less symptoms of reflux. You want to avoid overfeeding. We can do a trial of allergen-free milk or allergen-free diet in breastfeeding moms, or thickening formula feeds with rice cereal, which actually provides moderate improvement in symptoms. But it's not enough to recommend breastfeeding moms pump to thicken instead of direct breastfeeding. But if you're already using formula or pumping, it's a great solution. So when we look at the natural history of the disease or reflux, we have found that after the age of around 4 months, there is a huge drop off in the number of infants that are going to be affected by or complaints of reflux. So that means a lot of infants tend to get much better after 4 months. Between 4 to, I want to say, 7 months, there is the greatest improvement in infants. By 1 year of age, it is going to be completely resolved in most infants. In terms of medications, we have 2 options, and like I said, neither are really recommended and neither are approved for use in infants less than 1 year of age for gastritis, but we do still use it in very severe cases. So they are going to be your PPIs or proton pump inhibitor and the H2 blocker or a histamine 2 receptor antagonist blocker. Big words just to mean that both of them limit or inhibit the acid secretion in your stomach. So they both come with side effects, unfortunately. The H2 blocker can cause irritability and headaches in infants. And so the PPIs, when we look back at it, a lot of them were associated with a slightly increased risk of pneumonia and something called a C. diff infection and even gastritis, which sort of defeats the whole purpose. But obviously these occurred in a very small percentage of children, and in a lot of them, they did have some improvement, so it's probably worth trying in very severe cases. And so we only use them in infants with proven esophagitis by biopsy, which is really rare. We hardly ever do biopsies in these infants. Or with severe symptoms such as poor weight gain, extreme fussiness, even when lifestyle changes have been implemented and not helped at all. So infants that have severe GERD will sometimes have a syndrome called Sandver syndrome, where the pain is so intense, the pain of the reflux acid content in the vomit is so intense that they tend to have like spasms of the arms or legs. They arch their backs, they turn red in the face. Sometimes they may even have periods of apnea, and that means they hold their breath or they stop breathing for an extended period of time, which can look very scary. Sometimes these can look like a seizure. It's really, it's not pleasant at all. And so in those kids, we would probably try the medications. There are a couple situations where the vomiting or what we think might be reflux may be something more severe or more serious, and those babies will need to be evaluated more carefully. And so things to look out for would be if the vomiting starts around or after 6 months of age. That's very, very rare, not typical with reflux. So if the vomiting becomes bilious, or meaning that there's bile in the vomit, so it's bright green or like a bright fluorescent yellow. If the infant or baby has been constipated for a really long time, and then they're vomiting and getting really fussy, if they have a fever, if they are becoming more lethargic or sleepy, or really difficult to wake up and arouse with the vomiting, or if the fontanelle that we mentioned is bulging, it's really big and bulging, and they're appearing less active or sleepy to you with the vomiting, that's a red flag. You want to get that checked out immediately. Or if they're vomiting and their tummy is a little distended and seems to be tender or painful. So you press on it and they're crying, they're fussy, and they're really tense. All of those would be instances where you would want to get them checked out. That is not typical reflux. Okay. So just to wrap it up, in most infants, the reflux is going to be physiological or normal because of this weakened muscle. In infants who have severe reflux, where the quality of life is being affected, they're either super fussy, irritable, not gaining weight, there are options that we can try before we get to pharmacologic or medical interventions. And in babies who have that vomiting with other symptoms that we mentioned, those red flag symptoms, you want to get them evaluated by a healthcare professional immediately.